our K-Quip team be one of the facilitators in the breakout rooms. So with an NHS England and QI background, so can see
Thanks,
it from all
Georgie.
sides.
So, so from the Preston team, we've got Sarah and Emma and Alice. Have you got anything to share with us, Sarah, and the team? Do you want me to, I'll stop sharing my screen with the agenda on. So I know when we visited Mo, he'd done a great presentation and kind of set the scene really, and there was a lot of things on there when myself and Libby came to visit the unit. We weren't too sure whether the whole of that slide deck that he had was manageable in the short term, but obviously there was a few things that you were going to pick out on, and we did some process mapping when we came, didn't we? Are you able to share the screen at all?
I'm just trying to find that process map. Sorry.
Or do you want me to try and share it?
If you've got it handy, yeah.
Okay.
Oh, I found it.
Have you got it?
Oh no, that's Emma's one.
Let me have a look.
Hello, can you hear me? Can somebody say hi?
We can hear you and see you.
Hi, Shamila.
Hi, Shamila.
Increase my volume. Sorry, we were running late.
We were just trying to share that workflow that we did at the last session, Shamila. We're just trying to find it. The process mapping thing.
So
Here we go. I've got it.
I think we were supposed to end first, isn't it?
What was that? Sorry, Shamila.
Were we supposed to present something for the first 10 minutes? Are we?
Yeah, if you've got something, yeah.
Yeah. Can we just share this? Yeah, just share this. Come have a seat. Mo and I, we had a bit of an issue with the internet.
Just whilst Mo and Shamila are getting that, I'll just share the screen because I've got the Preston process map that we did.
You see it?
Ah, yeah, it's there. Okay. So what is?
Okay, right. So, okay, thank you. Oh, sorry. Just where are we? Just bear with me.
No problem.
Can you still see the slides? Or
we could see them, and it's gone into a blank screen now.
Okay, can you just set it up for me because I.
That's it. Yeah.
Okay.
You see it?
Okay, thank you for being patient. I'm sorry, we just got a bit.
That's okay.
Okay, so we are the Royal Preston team. Thank you for giving us this opportunity to do some quality improvement work with you guys, and thanks for all your support. Okay, so we'll start off with our area for improvement. So a bit of background. We cover quite a vast catchment area, geographically quite a large area. We covered by 3 or 4 trusts. So this project, the thought processes in our mind started when the GERF committee gave their report. And then we got in touch with our CD and we kind of identified some areas that we want to highlight and improve first. So one of the main things was, because of the large geographical area, we had a lot of variability in approach towards our advanced CKD patients. So that was the first thought process, that we want to streamline the service. Particularly East Lancs in our entire area was a bit lacking. So we are in the process, and we've done a bit of it, and there's more to do, of course. So identification of patients, timely referral to our advanced CKD clinics. That was the first topic. Second topic, I think this is quite a common topic for many of the units. So definitive dialysis access for both hemodialysis and for PD. For us, we had a deficiency in a surgical PD pathway. So our focus in terms of PD access was that, because we have our own medical PD insertion list. And thirdly, the other area that we were looking into, we had done some work in the past, and we're just going to take it a bit further on, was establishment of an acute PD service. So these are the three areas that we are currently working on. So I'll go on to this slide first. So our stakeholders. So the way we worked out that we met up in May, isn't it? All of us met up in May. And then through June and July, we had a series of these small meetings. Mo had kindly set up this Microsoft Team, what's it called? Channel, yes, Microsoft Teams channels. And individually, we were meeting up with different teams of our, who are the stakeholders in this. So we met up with the Kidney Choices team, who are very much part of the advanced CKD clinic and the definitive access planning. And then we also met up with the home therapy team, which is looks after the PD side of things and for the acute PD pathway. And that led us on to middle of July, when Andy and his team came and helped us through this excellent process mapping for all the three projects. So I'm just not going to discuss any of this. So I'm going on to the next one, but you can see we spent 3 hours on each of these areas of improvement and came up with this wonderful process mapping diagrams. Any questions so far? No. Okay. I can't hear you, but I guess the answer is no. Neither can I see you. Okay. Right. So then the challenges. Yeah. So, I mean, this is not a new challenge. It's always been a challenge. We have a vast geography, different trusts. So, you know, certain things we have to make best uses of our resources in terms of nursing time and all of that. So while we are trying to make some improvements, there was this thought about individual nurses going to the peripheries and checking a few fistulas, but is that the right way to do it? So those kind of things we are all in process of discussion. So along with the vast geography, the other thing linked in is care close to the home. We're looking into that. One of the challenges, and I would say it's challenge only at the beginning, is we've just implemented a new renal IT service sometime in March last year. It's a very good system. However, it needs to maximize its potential functionality. So that's where we are. And I think Mo is in the process of meeting up with the IT lead for us. And the other challenge is always, you know, on one hand, we are planning to increase our home therapy numbers. But as the home therapy team will be able to tell you, the current resources we have in terms of space, possibly even nursing staff, we can, I think, train 2 people at a time on PD. So, you know, there are some challenges over there which we need to look into further. So those are the main challenges. Okay, so now the good bit is we have made some progress. So we've assembled our teams and we've also established this communication channel. It's a channel on MS Teams where we store all our documents and everything, and it's visible to our entire team. So that's number one. Then number two, we've actually started we started one of our advanced CKD clinics in East Lancs. I think the first one was in March, isn't it? And we're kind of improving it slow by slow. But yes, we are happy with it, and we've seen some benefits of it already. And we're due to so now, all over Preston, once the last unit is set up in John Sagar in Burnley in November 2023, I think the entire catchment area of Preston will have advanced EKD clinics. So that's some progress over there. Then we've already made some links with the surgeons in MRI who are doing our surgical PD insertions. And as of news hot from the press, this is news from last week, in Preston, they've recruited a new gastroenterology surgeon who is interested in doing PD catheters. So we've been in communication with him. And for now, we are being supported by another trust, but we hopefully eventually will be able to bring it in-house. So I think, and the final slide on how are we going to measure our project. So our suggested KPIs would be the first one, the percentage of advanced CKD patients with EGFR less than 20 being monitored in our advanced specialized clinics. Part of that same project would be percentage of incident RRT patients with definitive access. Then overall incidence of home-based therapy, whether we've managed to increase our numbers or not. And the other thing, I've not discussed this with Mo, but I just thought about it. If you're going to do an acute PD service, we need to see how well we are doing on it. So maybe percentage of acute PD patients on PD after 3 months, 6 months, we'll have to work that out. We've not thought in details. And finally, patient-reported outcomes and shared decision-making feedback questionnaire for the patients. So that's all what I've got to say. Anything else, Mo? No? Okay, thanks very much. Okay, end of slideshow. And
Thanks, Shamila. Thank you.
yeah, we're coming back in. I want to show them this picture, but it's okay.
Anu, you got your hand up?
I do. Well, thank you, Shamila. That's outstanding work you've already done. So thank you so much. It'd be lovely if you could share your self-set KPIs for the projects that you are actually doing with Andy, because we have requested some baseline figures from across all of the units. I mean, some things that are common to all units, but some things that are project specific, and we would certainly love to look at that as well, if that's all right.
Yeah, sure.
Thank you. Thank you so much. Thank you.
I think what we found when we came up to Preston, Shamila, was the size of the area that you've got to cover. It's vast, and the work that you're currently doing is brilliant. We've managed to process map the kind of kidney choices pathway in a sense, haven't we? We've gotten up to the access part of it, and I think we mentioned that when we were last there, didn't we, Rebecca? That that's something we can revisit. Probably after this, after this workshop in the future, we can map your sort of pathway from an access point of view.
Yeah.
And then that's kind of the whole kind of service, really, isn't it? From the sort of the big from the referral process. Yeah.
Starting dialysis. Yeah.
Yeah.
Is the PD surgical pathway up and running then, Shamila? Can I just check that?
Yes, it is. We've had 4 or 5 now, isn't it?
Oh, wonderful. Okay, great. Thank you.
Rosie?
Yeah, just a quick question, sort of with clinical interest, really. Have you kind of set criteria for which patients need surgical and which patients are suitable for percutaneous? Because that's something we've sort of grappled with in Salford.
Yeah, so I think we need to do that meeting with the surgeons. We've not set up that meeting. I think because of this holiday period, I think David went off, then I went off, and then Mohyuddin wasn't there. So not any definite criteria is in discussion with the surgeons. However, some of our polycystics with very big polycystic kidneys, and we scan them and they've got cysts across the midline, I send them off. I do assess the abdomen. I'm one of the assessors. So and lots of surgeries in the past and stuff like that. So very wishy-washy at the moment. So we do need to sit with them and set some definite criteria. Yeah.
Yeah, I would say it's probably. Sorry, carry on.
No, I was just saying that we have done medical insertions on cesarean, 3 cesareans in the past, but they're all below, transverse and no vertical incisions. Yeah, we've not done them. So, but we have done on patients who've had abdo surgery. I mean, lap chole, then cesarean, smooth, uncomplicated surgeries. We have done quite a few.
Yeah, so basically it just depends on the assessor on the day itself. I mean, even a very obese abdomen, and we feel actually that we're not comfortable doing, we would actually send them or refer them.
Yeah. So I mean, it might be worth sharing between us in the region, what our criteria is, because it probably would be fairly similar, just to get some kind of unity and maybe some shared learning. In our department, it sort of those criteria came from the people who do the percutaneous, which ones they didn't feel confident to do. And the surgeons would be happy to do the PD tubes on anyone that we ask. But obviously there's a bit of a delay with that, isn't there? Yeah. So if they come on the day with a GFR of 7 or 8 and then we realise we can't do it, then it might be sometimes a month or more before we can get a surgical one at MRI.
So we do, if it's not straightforward, there's some issues, some surgery, we assess them a little bit earlier on. Yeah. But for us, it's been similar weight for the surgical team because, we've not really managed to have too many surgical lay put in. However, if this, as this MRI thing is up and running, sorry, Mo, and also if we get our gastrosurgeon to do our PDs, we hope we'll start avoiding this delay. We do assess a couple of weeks before at the point of referral when the home circumstances are checked out. We do bring them into our clinic, not a formal clinic. They just come in on a Tuesday afternoon and we check out their abdomen, whether they're fit for medical or not. But the consultant has to raise the concern. So whoever's referring the patients. Sorry, you were going to say something?
No, just what I'm about to say actually, it just needs to be formalized, and it's just to do with the time of referral. So we manage actually to refer a patient early on, very early on, before even the timing for insertion, in anticipation basically, and just to kind of keep them in the pathway. And when we started, actually, we had instances where we asked for urgent tubes and so on and so forth. So probably it's something that we need to kind of work on in our pathway, the timing of referral and timing for assessment.
How many patients have gone over to MRI at the minute, Shamila? How many have gone for the surgical route?
Becca, 4 is it, or more than that? Second day, did they do 2?
Oh, you're on mute.
You're on mute, Becca. Yeah.
Sorry, yeah, I think it is about 4, yeah, something like that. There was, I think we've had 1 failed so far, but yeah, that's it.
That's great, actually. Thank you.
Any other questions for Shamila and Mo and the Preston team? It's a great presentation. Thanks, Shamila and Mo and the team. Should we move over to the Manchester team? John and Krisha.
John, did you want to go? Did you want to go first?
I'll go first. That's fine. Okay, just hold on a second. Oh. Is that shared?
Yes, John.
Yeah. Okay. Okay, so I'm part of a few projects, but this is the one that's most relevant to what I do. Okay, so my job is I'm a transitional dialysis nurse, and I'm still a bit confused what that means really myself. But I'm basically the person that people refer to if there's a patient that they want to talk, they want to be considered for home therapy or self-care therapy. And that's a big part of my job really. Now we've opened up in the last couple of years a dialysis assessment unit that captures a lot of patients, and we've had really good results with that, with patients moving on to self-care or home therapy. And basically it's patients going there from the start, and it's flipping the philosophy, having the opportunity from the start to learn from scratch and build up the confidence, and hopefully they go on to a more independent therapy. But there are patients who bypass this, go straight out to satellite units, and the main concern was basically that the patient's not getting the opportunity, and not the opportunity for the discussion or the assessment for a more independent dialysis therapy. So that was so I've listed all the problems that I thought was there, and Anu and some of the other team thought were there as well, and that built us kind of sent us toward the aim that I'm trying to achieve. So the patients were bypassing dialysis assessment unit on the start to dialysis. They're slipping through the net, and they're often not. They're unknown to the advanced CKD team and the home therapy team. So some patients are not given a proper opportunity for assessment for the self-care or home HD. The referrals for patients from the units, it was very much on an ad hoc basis and down to the individual. There was no consistency, and some places were just better than others at doing it, really. More referrals. These are all things that I realised, and actually I've got figures to prove it, really. But referrals for patients from the satellite units, most of the referrals I would get would be more so from the consultants who were already involved with home dialysis. So it was at the forefront of their minds, and they would address it. And I don't think there was much difference in the patients on different units. So I think that was the reason, possibly because it was more in their mind and in their mindset to push a home therapy. There were more nursing referrals from the unit adjoining the dialysis assessment training area. So that's probably, I thought, likely due to increased awareness of the staff and the patients who ask for it as well, because they're aware that it's there. This was always been consistent. I worked very closely with the advanced CKD team, so they would always give me the heads up on patients who they felt that needed follow-up and potentially may change their minds or be good candidates for a home therapy. But at the time, maybe if they were urgent starters, they just couldn't say, they buried their heads in the sand and they just couldn't make any decisions. And that's always been quite consistent. And every time I've seen a patient, the reason I know that, every time I've seen a patient who's gone through, slipped the system and gone through to the units and they've had a referral, they've often not had any input whatsoever from the advanced CKD team. Just another observation I found, that when I did get told about one or two patients on a unit and I'd go to the unit, it would prick the minds of the staff on there, and they'd say, "Oh, I've got this other patient who I think you should see." And I just think it was just kind of that, maybe just being a face there, pricking the minds to kind of to stimulate them and think about other patients, that maybe that was something that I needed to think about. So my aim was to basically all maintenance in-centre HD patients who have the potential to pursue self-care or home dialysis should have the opportunity to do so. That was really the main aim. So I have got some figures there. I'm going to flip through them because I think they're a little bit too personal and it separates out the units and things. I think that's more for our local teams meeting. I'm not sure what Anu thinks about that, or our consultants meetings and staff meetings to feedback and things in the future. So the change ideas that I had was basically to increase staff awareness. And a couple of things that I thought about was maybe establishing an assessment for self-care or home therapy and a mode of referral, and make it more like a routine practice for the medical teams, but also for the nursing teams to have some more consistency. So maybe develop some 2 or 3 link nurses on each unit and establish a means of referral for them as well. So my plan was to develop an easy guide and a quick option on our computer system for the medical reviews and assessments. So it becomes much more of a routine. It's a kind of a yes/no kind of tick thing that could take a couple of minutes, depending on the conversation. And to consider this as all initial assessments for the consultants when they first do an assessment on a patient that attends their unit. And maybe also on follow-up reviews. We need to get an agreement on the frequency that that this would be required. The assessment's already been done on Hive. A consultant did it with me, and probably we just need to have a couple just have a look at it and test it and obtain feedback for that. I just want easy options for referral, so I've got some ideas for that. Establish the link nurses on the units, provide some simple guides for patients who should be considered for the nursing teams. Attend the consultants meetings to discuss initially, and also I could feedback here in the future also. Attend unit managers meeting, which I've already done, just to explain what the plans were and to reassure them that there wouldn't really be any work involved for them. Okay, because they're always so busy and understaffed and things, so we just need to make it simple as possible and achievable, and arrange the visits to the units. So I've given out dates, to initial dates options for people. I'm just waiting on all the replies, and then I'll probably revisit them every maybe 3 months or so. But I think that's what we kind of agreed with the nursing teams. And I can also feedback at these meetings as well, and at the unit managers meetings. So the initial assessment for the consultants, it's a really simple thing. So this is kind of the guide that happens really, but it's just a click, 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 refer, okay, or not refer, or if not referring, why, that kind of thing. It's pretty simple. So you can see from that really, is the patient considered for self-care, or can they be considered for self-care or home HD? If it's yes, ask the patient to, if they're receptive to having some more discussion about their options. Obviously, I want them to stress that there's no expectation or commitment, because I know if you put pressure on patients in this situation, they will put a brick wall up and say, no, I don't want it. If yes, ask them, would they prefer this conversation to be at the unit or at home? Eventually I will, if they want it on the unit and they do want to progress, I would do a visit at home anyway. So preferably at home, I can kill 2 birds with 1 stone and assess the home as well. If no, fine. And basically a really easy referral. I'll clear that up with the consultants, but they can email me, they can copy me into the clinical letter. The letters can even just be copied into me on Hive and they'll come to me as a message. There's lots of different easy ways for it to happen. I just want it as simple as possible and as quick as possible for them, so it's not not too much of a chore. And thoughts on how I would measure it. There's probably other measurements as well, but the main thing is the number of referrals for the self-care and home HD assessment, number of patients who have commenced self-care, home HD from in-centre HD, and review where the referrals have come from and who has sent them. That's it.
Thank you, John. Thank you.
Thanks, John.
Okay.
Happy for me to go now?
Please.
Can you see? Have I shared my screen properly there?
Yeah.
Can you see it?
Yeah.
Okay.
Thanks, Krisha.
Okay, so Siobhan and I are in the Add CKD team. So Susie normally with us, but she's on.
Sorry, could you make that into a bigger screen, into the slideshow? Just makes the screen a bit bigger. Thank you. Is
that better?
Perfect, thank you.
Okay. I can't see any of you now, but that's okay. So I'll just go to my next slide. So the reason, sorry, I can't believe John did a better job than me on this. Okay, so we looked at what was going on at present in our clinics, in the Add CKD clinics, and around our patient education. And there was a few things that we found or felt that we were lacking in. And some of that was based on what patients said to us, and some of it was what we just kind of noticed ourselves. So with regards to resources, we felt that there wasn't enough variety or appropriate educational materials to aid in decision making. And we were quite limited. So we show patients a workshop in clinic, so peritoneal dialysis workshop with APD and CAPD. We give them an information booklet. We talk around hemodialysis and show them pictures. But we felt that for some patients that wasn't enough or it wasn't suitable. So I'll tell you further on what some patients said to us about that. The environment that we were in, we have small clinic rooms. We don't have any access to use any other rooms. So previously we had another room on the renal dialysis unit that we could use to take patients into there outside of clinic times, but we're no longer able to use that. We don't have any space for a permanent setup of our workshop. So we felt that that would be useful as well. So Susie has been liaising with somebody from the trust about getting some kind of multimedia room that patients can go into outside of clinic times or during clinic times for some of the extra things that we wanted to give to patients education-wise. So there was a few things here that we felt was showing us that we had limited education materials. So we felt that what we wanted to do was we wanted to improve the decision-making process for patients, to provide educational materials that we could use outside of the clinic environment. So Siobhan and I looked at making a film about peritoneal dialysis, because we found that some patients were coming to clinic and they were still, after we demonstrated peritoneal dialysis, they were still a little bit confused about the difference between CAPD and APD. So patients would say things to us like, do you have any patients that I can watch doing this? Do you have anything I can look at online? Is there anything that I can show my partner or relative about this? Do you have things on YouTube? So we heard that from various patients and felt that it would be useful and it would enhance patient education if we made a film with real patients doing both CAPD and APD, and patients talking about how they found the treatment, how they felt doing the treatment, how it had impacted upon their lifestyle, pros and cons of the treatment. So anything else that you want to add to that, Siobhan?
No, well, I think the longer view was to start with PD, but hopefully in the future to look at developing a video or a film for each of the modalities. But initially we were just starting with peritoneal dialysis.
So on this one here, we've just put who our stakeholders are and how far we've got with some of this so far. So we had to speak to, well, we had to include our matrons and management who had to agree the funding for the project. So we've had a few meetings with them, and Susie, as I said, has had meetings with somebody about having an audio visual room. So Siobhan and I have made really good progress so far. I think Susie's had a few obstacles with the audio visual room, and Anu might want to add something about that later, because I think Anu's got some information about that. We had to speak to the PD companies. So we spoke to Baxter about using their products. Did they have any educational films about PD? And we obviously had to ask permission to use their products, because that's what some of our patients are using in their homes. We had to find patients that were suitable to take part in our film. So we liaised with a few patients. We were very lucky. We've had some very willing patients that have been fantastic and have allowed us to go into their homes to make the film. And we've had family input as well with that. And then we've had quite a lot of input from medical illustrations. So Siobhan and I so far have been out to a patient's home that does CAPD, and also a patient's home, a patient that does APD. And we've taken medical illustrations with us, and we've filmed both those patients and their families doing the treatment, and then talking about how they find the treatment, how it makes them feel, have they made it fit into the lifestyle. So we've got so far that we've filmed all of that. We've done a lot of cutting and moving around We've done a voiceover. We've involved someone else from Medical Illustrations to do a bit of animation at the beginning. So we've actually, I feel we've made very good progress with that so far.
Yeah. Did you tell the important thing? We've actually got made sure there's Mancunian accent in the background. Not
Yes,
the AI generated one.
Yes, so I did the voiceover.
Oh, did you?
Last week. Yeah. So it is my Mancunian accent on the film. So I did it for both. The plan is that if we do more films in the future, because we've ideally, because we've started doing this now, we've learned so much from the process and who we need to involve. It's been a real learning curve for us. We would hope that in the future we can do also a film on a patient doing home hemodialysis and a film on a patient going to DAU. And Siobhan might want to do the voiceovers for those. So there's been a lot to it so far, but we've really enjoyed it. It's been a huge learning curve, and so far we have put out a first draft of the film, and we've had feedback from the community team, some of the medical team, the expert patients have all given feedback. Anyone? PD team. Anybody else? I think that's it. Yeah. So when we have we're almost finished. Yeah. We've got a few final touches, and then we will put that out again for more feedback to see what thoughts are. So then when it's all completed, then obviously we're just recently been thinking about how we're going to measure how successful the project has been. So our overall aim was to increase the understanding, so patients' understanding of the difference between COPD and APD. So, and you know, we would welcome any suggestions for this. Really, we thought that we would put out patient questionnaires to patients. We thought we'd have to do questionnaires before they have viewed the film, and then questionnaires after they have viewed the film, to see really if it has increased understanding. So at present, our plan is to ask patients who are undecided on modality that come to clinic, those that are still not sure what type of dialysis they want to do. And we would also ask those that have decided on modality. We thought that we should ask patients that have attended clinic at least twice and seen the PD workshop. We thought we would exclude those that are opting for conservative management. So this is not, we've not finalised any of this. These are just some of the thoughts that we have at the moment. What we're working on at the moment is how we're going to word those questionnaires, and that's the bit that we're just not quite sure on at the moment. How we're going to word them. You know, do we do like strongly agree, strongly disagree? So do we do more open-ended questions? So we're not completely sure on that at the moment, but we would welcome any advice if anyone's got any. And that's it so far. Susie will, if Susie was here, she could probably update you a bit more about where we've got with the multimedia room. But I don't know if you know anything about that at this stage, if there's been any success.
It's just waiting for, so the room location's been agreed in principle. So we're just waiting for the management to sign off the use of that estate area. That's all. So hopefully we'll have something up and running before the end of this year.
Okay. Any questions at all?
Rosie has a question.
Rosie?
Yeah, fantastic piece of work. You've really got going with that so quickly. I'm really impressed, and hopefully the impact on this for patients is going to be really valuable. I guess one of my questions is the video very sort of specific to how things are done at MRI for patients, or is it something that would be applicable to all kidney patients in the region and maybe beyond?
That's a good question. Well, Siobhan was previously our PD nurse, so Siobhan might be able to answer that. But I think if the teachers COPD, you know, if the people are doing 4 exchanges a day, then that's what we are discussing as showing a patient doing that. So, and the APD, I suppose it depends if they're using the Baxter machine, which is what we're using. But I would think it could be used.
Yeah, the only thing that may be on the CAPD video, one of our patient talks about the follow-up post training, so that might vary from trust to trust. But it's not supposed to be a training video, so it doesn't sort of step by step show how a machine is set up. And there is a lot of patient sort of perspective and patient experience. So I think some would be usable in other trusts, but it may be with the caveat regarding that follow-up that might not be applicable to all.
Yeah, because we've got Georgie here, who's the K-Quip lead for the Day Life project. So Day Life is dialysis at yours. So it's a home therapies dialysis project. That's the name of the national project. We've sort of been less likely to call it that in the Northwest for reasons I'm not quite sure, but maybe something that could be useful for that project, Georgie, and maybe other places around the country doing something similar. I'm not sure.
Yeah, thank you for that, Rosie. I've jotted it down as a note to pick up actually. I think it would be such a valuable resource to so many different areas.
Well, we can certainly, our aim as well was to have it available on YouTube, as well as maybe a QR code on some of the letters. So if it would help, we could always share it or share the link if people want to see it, maybe once it's been signed off.
Yeah.
That would be great.
It is a concern. We wanted to keep it short, didn't we? Because I thought I don't want patients to think, oh, this is another thing I have to watch and, you know, them just switch off. So we've kept it quite short, 5 minutes each on both. And very much from the patient perspective, because we have found in the past that patients really appreciate hearing other patients talking about their lived experience. And we really wanted to capture that on the films, didn't we?
Absolutely. I think, is there a plan, Andy, for a sort of outward facing website from Northwest Kidney Network where things like this could live as well?
Yes. Yeah. I know the pediatric transition policy. So Tina wanted to do some education videos focused for the school teachers, and she wanted kind of just a simple login so she could kind of measure the teacher access to the website, if you like. So the plan is for the network to formulate another website away from Futures. We estimate that it will be done this side of December, so it shouldn't take us too long to set up. And yeah, we can place videos like this and going on, from a measuring point of view, you can also look at who it is that's viewing the videos. That's what Tina actually wanted from that the other website, if you like. She felt that Futures wasn't really suitable really for that. But great work, John. I noticed your hand went up, and Alice as well.
Yeah, I was just going to back up. What Siobhan said. It is generic. It could be used, apart from the little bit at the end when she talks about the follow up. Siobhan said everything I was going to say. That's why I took my hand down.
No worries.
Okay.
And Alice.
Hiya. Yeah, I was just wondering. Sorry if I missed you saying this, but is this something that patients would look at when they're on their own in their own time, or is it something you'd be viewing with them when you see them?
It was aimed really for patients to look at in their own time, just because we found some people are still confused after seeing the workshop. Because when we see them in clinic, they're often overwhelmed, got a lot of information to take in. We're showing them PD, and we know sometimes when they come back, they're a bit confused about the differences between CAPD and APD. So we thought it'd be useful for them to watch it in their own time, go home, they can either click on it and watch it on YouTube, they can either do it through, we have my MFT here, so patients, we're hoping that we can set up a link on that, so when patients log on to look at their own results and things, they can click on a link there to watch it. And we just thought it's something they can watch at home in their own time. It's not very long, it'll only be 10 minutes long, they can watch it with the family. So that was the aim, that they could watch it in their own time. If we do manage to get this media room in the hospital where we can have a permanent setup, then the idea would be that we could also have it playing in there as well. So that would be maybe on if patient wants to come in on a non-clinic day, or before or after clinic if they wanted to go in there to have a look. So that would be the plan eventually.
That's good. It sounds awesome.
Thank you.
Rosie has a question.
Yeah, just coming back to the measurement, as you said, it's really important to measure the impact of patients watching the video, because there's no guarantee that watching a video is going to be helpful, though we hope it would be. So it probably is something that requires probably another specific little meeting with your project, and maybe Leanne and Georgie. You know, KQIP's got quite a lot of experience working on patient-reported experience measures and things, so that's probably worth having a separate little meeting on.
Yeah, any advice at all is very gratefully received.
Thanks, Rosie. Thank you so much, Krisha and John. The Whittle team, Angela and Kelly. And Lamise.
Okay. Sorry. I'm just wondering, is my screen sharing? Can't see.
It did, and then it's disappeared again.
Okay.
It was there, and then it's gone.
Okay, I'll try again.
That's it.
It seems to have gone. Okay. Thank you very much. Thanks for the opportunity to present our latest QI kind of project from Wirral University Teaching Hospitals, and we cover Wirral, Clatterbridge and Countess of Chester. So we felt that the area for improvement that we wanted to look at was to increase the prevalent home therapy numbers in line with the GIRF recommendation, etc. We are quite significantly below the national average for our home therapy numbers, and that's both in PD and home hemodialysis. And as home therapies team, we cover both modalities, so it just seemed to be we might as well try and do both at the same time. So the three projects that we kind of decided to focus on with this QI support was firstly to develop the Shared HD program within our area. So one of the things that we feel that we want to do is to kickstart the interest, because I think with Shared HD in our units anyway, it seems to sort of fall off the agenda quite easily. So, and it's just such a brilliant modality for patients to use, but I think because it doesn't sort of have any kind of money attached to it or targets attached to it necessarily, it's very difficult to measure. So we just felt what we need to do first of all is kickstart that interest again with the nursing team and try and get some patients involved as well. So, very, very handily, the Day Life virtual event on the 28th of September, we're trying to sort of promote that very much within our team and see if we can get to that and hear how other places have done. Because I think one of the things that we're learning with QI is to reach out to other units that are doing it well and find out what works best. So what we want to do is have Shared HD as a concept across the three sites that we cover, rather than just having it focused on one unit. But what we would like to do is, obviously with Shared HD as a home therapist myself, we want to increase our home HD numbers. That's our aim of the game. So we've identified our satellite unit at Clatterbridge as the main home hemo training unit, if possible, because we felt if we were trying to replicate it 3 times, it's going to be quite difficult to do. So we'll use the Clatterbridge site as our pilot site. And obviously you've got trained patients, the number of staff to patient ratio is better in the satellite unit. So we feel it would be better to try there, but we also do need to be agile and be able to sort of respond to patient needs as well. So if a patient does want to try home hemodialysis and for whatever reason isn't able to go to our HD training unit, then we would take the training to them. And so with that on board, we're trying to support the home hemo training from the home therapy nursing team as well, because obviously we can go to different units quite easily. Our second area for improvement to increase our prevalent rate on PD numbers is medical PD catheter insertion. We've never had one within Wirral. We have got a surgical insertion, obviously, and it works very well. We've worked very hard over the last few years to have good links with our 2 surgeons that place PD catheters. Kelly and I have weekly meetings with the surgical business manager to try and identify slots for when patients can go in, firstly for assessment for PD placement, and then secondly, when the time's ready for them to have their operation scheduled. But obviously, looking at, again, national practice, medical PD catheter insertion is something that we do need to look at. So Dr. Tahar, who's our clinical lead for home therapies, is leading this area. And she's already got the contracts in place with a local trust in Liverpool and is developing the training with that as well. So everything's going to plan with our medical PD catheter insertions. We just need to have some patients over at the Royal where Dr. Tahar can go over and assist and start the training. And our third area for improvement is to look at the PD take-on and our attrition rates. I think we feel that our take-on rate is reasonable, but again, we don't really measure it that accurately. And you know, if you can't measure it, then you can't sort of prove what you're doing, I guess. So what we've done is we've gone back over the last 3 years and analysed our attrition rates from PD. So it seems to be some sort of headlines on this. Our attrition rates, they do seem to be quite similar each year. We lost 16 patients in 2020 and the same in 2022 and 17 in 2021. So we're losing patients, and roughly the patients that we lose to in-centre hemodialysis, it's about a 50-50 split. 50% we're losing because of infectious complications such as peritonitis and exit site infections that we can't resolve, and 50% seem to be about non-patency of PD catheters. So they're fairly small numbers, but what we're going to do next is do a bit of a deep dive on each of these patients and audit them and see if there are any kind of similar themes really that we can look at to see how we can improve things. In 2023, we've already set up some changes as well, especially to kind of prevent our peritonitis drop-off rate. So what we do now with every new patient that starts PD, they have weekly support from the home therapies team. So we go through things like hand washing, exit site care. We've only recently started to use mupirocin in about the last 18 months. So it's about trying to make sure that that's embedded into practice. And we're hopeful that obviously that will help improve our exit site infection rates, which will then keep patients on the therapy of choice for longer. I think, oops, sorry. I'll go back, apologies. I think one of the things we've learned from our previous QI projects, which we felt stalled a little bit, is stakeholder engagement and sharing the data. So for this time, we're starting again, and we're very lucky to have Dr. Tahar with us as our project lead, and we're having very regular meetings with Lamise about this. And what we feel as well is it would be Dr. Tahar's responsibility for cascading the information that we're presenting to the stakeholders. Because within our trust, we've identified some of the divisional management team as the sort of stakeholders with more power and more impact on the project. So we just feel we need to communicate with them a little bit more. And it's quite difficult for us as a nursing team to have that access, whereas the consultants meet regularly with the divisional managers. So Dr. Tahar will present our kind of projects each time there's an opportunity presented to us. I've mentioned before that as a nursing team and a clinical team as nephrologists, we're meeting monthly to look at the project reviews, and also we're going to do like root cause analysis for any infectious complications that we have with our patients, just again to see if we can improve our kind of continuing on therapy rates, I suppose. And finally, again, one of the communication plans that we feel that we need to do, and one of the things that we were sorely lacking from our previous project was data. And Andy, I know that you've sent some information and you're going to have a sort of dashboard soon about the data that NHS England want. So we just want to be able to link that in with our local data and maybe just have one kind of dashboard that we can use that's going to be easily accessible with dedicated responsibility for staff members to fill in on a regular basis, rather than keeping information to themselves, which I feel was one of the issues that I had as well as home therapies manager. I was aware of the data. I had kind of hunches about what was going on, but I wasn't good at sharing that information with the team. So I think, interestingly, QI teaches you a lot about yourself and your own practice. So this is going to be what we're going to do moving forward. We're going to have a relevant dashboard. It's going to be completed regularly, and we're going to share and celebrate our success a little more as well. So thoughts on process mapping. Andy and Leanne came and we process mapped our education pathway, because again, we do feel that when we get patients in front of us, our education specialist nurse is fabulous at delivering the education, and we get really, really good feedback from patients. And again, we feel our take-on rate is reasonable, and if patients are suitable for PD, they generally choose it. Whether they end up on it is a different matter, because sometimes perhaps we're a bit delayed in getting that PD catheter in. So the process mapping certainly did encourage debate, which was a great thing. And we have identified a few broad change ideas. And again, I've mentioned previously, we have already implemented a few change ideas, which would be really, really good to be able to add into our QI project. And we're yet to do the shared HD and data analysis process mapping, but look forward to that. So again, measurement is one of the things that we want to do, and this is very much going on the QI philosophy, choose just enough. And I think previously we probably were a little bit too random in what we were measuring. And I think, you can make statistics prove whatever you want them to prove if you just present the data that you want to present. So we just need to have an agreed data set for NHS England, for us in home therapies, and also for our trust. I think we need to prove to our managers what we're doing, because despite our prevalent numbers not increasing, we feel we're working really hard, but we're just not getting the patient numbers to be able to show that. But if we're able to demonstrate that maybe our patient days on PD are increasing, then that will be enough evidence to our team not to try and pull our staff away from us. So we need to be able to measure outcome measures. Balancing process and patient experience is important to us as well. And linking with our local neighbours over the water in Liverpool, and see if we can sort of streamline data collection as well, and work along them, because we're a fairly small unit. So if we can add in other units with similar kind of pathways for training, etc., we might be able to sort of combine the data and have a little bit more interesting figures at the end of it. And again, quoting completely from Leanne, we'd really be pleased to pinch with pride from other Northwest units to how you measure your attrition rates on PD, what are the reasons why they come off PD, etc., and what have you done to sort of improve that, so keeping them on the therapy that they choose. And that's mine. Thank you. Well, that's ours. Thank you.
Thanks, Angela. Thanks, Kelly and Louise. Brilliant work. Any comments, Anu, on that work?
Oh, fabulous, Angela. I mean, I think you've always demonstrated through all of your presentations, your intent is quite clear, isn't it? I think you've worked so hard. And I'm so pleased to see that some of those things that we discussed at the outset about lack of PD catheter insertion service, and I think the conversation with Liverpool, Dr. Taha is now able to take steps to help facilitate all that. And I think that'll eventually make a difference. And I think if we get our processes right, it will show up in numbers in some time. That's the hope. But that's great work. Thank you, Angela. Thank you.
Thank you.
We are doing some pediatrician related work here in MRI. I'd be quite happy to sort of get my colleagues to share the data on pediatrician measurement, like you mentioned. I'll ask them to get in touch with you.
Thank you.
Thanks, Angela. I notice we've got Olivia and Hannah from Liverpool. I don't know whether you want to present anything today, Olivia, Hannah, or we move on to the next part of the agenda.
Andy,
Sorry, Louise, go on. Louise, go on.
Andy, would you be able to send the link to Nshaba, Dr. Naz? I think she was trying to join, but the link she had was wrong. So she.
Absolutely.
Thank you. Sorry.
Sorry, Hannah. Rosie just mentioned the other day that you were looking into some, was it symptom control for the dialysis patients, and we weren't sure whether you wanted to mention anything at this stage, or
we've got a short introduction to what we're doing. Happy to share if that's useful.
Okay.
At this time.
Sure.
Hi,
Olivia.
Oh,
that's
you're
fine.
right.
That's fine. Yeah. You sure had.
You've got the presentation. Yeah. We sent it, Leanne, but I don't know if it's better if we share it or.
Yeah, it's always best if you share. Thank
Okay.
You. Is that working?
Yeah.
Yeah.
Okay, so my name's Hannah, and I'm working with Livia and Natalie, our new appointed AMP, on looking at K-QUIP project in enhanced supportive care within our dialysis patients at Luft. Luft seems relatively still new to us, having merged two quite bigger units in Liverpool. So it's been quite a lot of change and learning process already within our department. So I'm just going to present where we're up to now. We're still at the very early stages, really. So we've been having the support of Leanne and Rosie to work through the 10 steps in QI, and we've kind of got to the middle-ish of this of these steps with our developing our change ideas and testing them. So just to run through quickly, in terms of this area and why we wanted to improve it, I suppose supportive care and dialysis population, we think is an unmet need, and one that is recognised within GIRFT and RSTP as a priority, and with the definite potential to improve care for our patients. National guidelines are being developed in terms of symptom management and frameworks themselves. And we've got local data and knowledge to know that we don't have any established structured way to address these to address patients' needs in a holistic way across both our Aintree and our Liverpool sites and the wider satellite units as well. And we know that we have a significant proportion of patients with high clinical frailty scores and the need for the comprehensive geriatric assessments that work alongside these things and providing holistic care. So what is enhanced supportive care? And some of these words come from the KDIGO controversies conference to help us. There's always a lot of debate about how we'll define this, but it involves services that are aimed at improving health-related quality of life for patients with established chronic kidney disease at any age. They can be provided together with therapies that intend to prolong life, such as dialysis, and supportive care helps patients cope with living as well as dying, regardless of life expectancy. And this graph, I think, just quite nicely summarises those points of supportive care, working with curative and restorative care to the point of end-of-life care and bereavement support. So it's a big topic, really. And in terms of assembling our team, we thought an MDT approach is important in terms of structuring this piece of work. So we currently have psychology, a pharmacy, recently appointed A&P, and clinicians with me and Olivia interested in the local involvement, as well as palliative care engagement. Obviously, there's a much bigger MDT that surrounds our patients, and important to reach out to all those members in this piece of work, which we're understanding how best to do so, really, in terms of dietitians, dialysis nurses, geronticians, therapists and social work. And of course, a lot of that is also determined by the resource available, as always. And then, of course, the other key stakeholders in terms of patients, most importantly, and having a patient representative of this piece of work will be really important, I think, in terms of oversight and guidance for us. But of course, our colleagues and then the wider healthcare system, given that these sorts of interventions having widespread ripple effect of a number of people that are involved in looking after patients, both in the hospital and in the community. So we're learning about the assembly of this team. So in terms of defining our project aim and scope, we've defined this as our aim at the moment: to improve supportive care provided in the in-centre haemodialysis population by the creation of a supportive care framework to identify patients' needs and address them in a holistic way with the support of an MDT. We recognise this is quite a broad aim, and our initial project is going to focus on symptom management within this piece of work. So we chose in terms of our initial project, which we hope will broaden into a bigger project. We'll be looking at our IPOS score and measurement of this. IPOS score is a palliative care symptom score that has a renal version and has been validated with measurable and reducible outcomes. And we know it's been used in a number of different centres with useful outcomes. So we want to focus our initial project on the use of this IPOS score within our dialysis units. And that's the IPOS score, if you are not familiar with it, with a number of different symptoms to measure, as well as asking patients about how they're feeling, about how they're supported with family and friends, and touching on how they share these kind of their feelings and experiences, and on how much information they want, and the practical problems associated with their care. So it covers quite a few of those important supportive care symptoms. So we plan to pilot the use of the IPOS within 2 haemodialysis units, with the aim of measuring eventually kind of the IPOS score in all our patients in the units, and to utilise our small local MDT to address symptoms, areas of concerns via either direct intervention or via referral to appropriate services, including therapy services, frailty service, palliative care team, social services, pain team, dietitians or other specialities. So we're in the process at the moment of process mapping. What we'll do with the kind of the pilot in the two units. They're going to be 2 in-centre dialysis units, and also developing a database using our dashboard and like database within our trust. Using the MDT and recording the outcomes and discussions and plans, and using our MDT also obviously to help us process map and development of these measuring outcomes. Implementing plans to address patient needs and repeating IPOS scores, and then to kind of record a kind of IPOS scores before and after intervention, decisions made within the MDT, referrals made to other services, and feedback from patients and staff. And then we're going to obviously move on to deciding the measurable impact of changes. And I suppose once we've kind of clarified that process map and the interventions, how we're using MDT, that kind of, we hope those measurable outcomes will come out of all of that bit of work. So to be continued. Sid? Stop sharing.
Thanks, Anna. Thanks, Olivia.
I don't know how to stop sharing, do you know? Do I just press
it? It should be, I think it's the top bar, I think, that at the very top it says share, and you should be able to click it and then stop sharing, I think.
Is that doing it? Yeah.
That's it. Well done, Hannah. Thank you. Any questions for Hannah and Olivia?
So can I just ask, Hannah, how frequently do you tend to seek the scores for these patients?
Well, I know that, so we haven't been using it regularly, the IPOS, you see, partly because we've been a little bit anxious about what we do with all that information. Yes. And not having a structure really to help us with that. So we hope that, so having an MDT approach with this, we hope will give us some confidence. In terms of measuring how frequently, that's something we were discussing just in our last kind of process mapping meeting, because obviously being able to, so I'd be grateful for any advice about that really. I know like in hospice care, they tend to, they can measure it weekly and see if the kind of differences in treatment plans and interventions, if they're having a help guide that management. Obviously, we're not going to be doing it as frequently as that with our dialysis patients. I suppose I think we were thinking maybe we would measure it, review people and record interventions, and then maybe measure it a month or two after that initial intervention was maybe our thoughts, but happy for anybody's suggestion with that.
I just wondered with some of these surveys, there could be a little bit of a learned approach to reporting the outcomes, isn't it? I think something like pain, breathlessness, etc. Of course, that's a report on the current state of the patient. But I think all else, would that actually run the risk of actually remembering the responses? And depends also on who is actually eliciting the response, I suppose, to some extent. So who, I mean, are you all particularly well staffed on your dialysis units? I'm just thinking if I just get to see the patient.
But no, we're kind of thinking through all those problems, and I suppose it's part, and all these reasons are why we don't use these score. I suppose part of the reasons we haven't used these scoring systems. So we hope we're starting with a very small group of our dialysis unit, and understanding through that process
as to
what are those practicalities and the learning from that, and then through the, because it's going to be quite a tight, I hope, PDSA cycle within that piece of work, because we're hoping in terms of recording the outcomes of that we'll have an electronic evidence of that. But again, there's all the complexities of people not wanting to use electronic devices and wanting to use paper, and then who transcribes it all electronically, and again, always resource. And the difficulty with, I suppose, supportive and enhanced supportive care is the resource, isn't it? It's bundled off into lots of anyway. But I think we hope that out of that we'll
learn from your experience, Hannah, and emulate a few years down the line. So great, thank you.
Thanks, Hannah and Olivia. Over to you, Leanne, for developing the SMART project aim.
Yeah, thanks very much. So thanks everybody for presenting. I feel absolutely, I'm really impressed. Everybody's worked so hard, and I'm sorry to say, but the hard work's going to continue. So for the next sort of couple of hours, Rosie and I are kind of just going to talk you through making a tighter project aim, a SMART aim, and developing driver diagrams. So sorry, but the hard work continues. So if I can just ask everybody just to get their phone ready. We're going to use something called Mentimeter. So some of you may already have seen this. So it's a QR code. We just want to get a little bit of information. It's anonymous data. Rosie, you've got your hand up, sorry. No. Okay.
No, I don't think so.
No,
it doesn't look like it's up from my end.
Okay.
I'm fiddling with my phone.
All right, okay. So just scan the QR code. We've got to move on. So once everybody's sort of logged on, I'll move the questions. And this is another way that you can collect data. So it doesn't need to be on spreadsheets and all that sort of stuff. So you can use Menti to collect some data. So we've got 12 people. Is that about right? I think that's about right. So move on. First question is, how confident are you at developing a SMART project aim? Like I say, it's anonymous. So this just helps us to know that we're on the right track of teaching you guys this sort of stuff. Okay, so everybody's voted there, and okay. And we're going to ask the same question again, except how confident are you at developing a driver diagram? And I think, you know, in the QI world, we use a lot of QI terminology, don't we? So I've put that driver diagram language in there purposefully, because that's, you know, we want to start using this sort of language. You know, I've already heard people talking about measurement and PDSAs, and it gets me all excited that we're actually using that QI language. So I think we've got everybody. So thanks very much, everybody. I'll stop sharing. And this is when your IT skills really come in, because you have to go from one thing to another. And you know, I even have to put Mentimeter to remind myself to do it. So yeah, we don't need to do that because we've done that. So this is about developing a project aim, and like Andy said before, we're going to share some dates with you at the end of this workshop. We want to provide and offer support again to help you develop your project aim, to help you develop, you know, your driver diagram. So what we're saying is that as we're due to have a comfort break quite soon. We'll go into our breakout rooms, but and we're saying that this is going to be a draft. Basically, it's, you know, you're not gonna have a completed aim statement or a completed driver diagram. We're just introducing you to the concept, and you'll have a draft project at the end. So delivering 10 steps in QI. It's great that everybody's using this. It's a really good methodology. We feel it's really easy to use. So now we're moving on to step 4, which is define that project aim. And that actually asks that question for the model of improvement, what we're trying to achieve. So we've put this step after understanding the problem, because now that you know where the project's going to go, that's when you want to develop your aim statement. So it's a written documentation of what you want to achieve, and it sets out a clear time frame for achieving it. You have to do it in collaboration with your team. So like I say, today we're just going to draft this up. But having an aim statement is a really good communication tool, because it's you'll use it with your project team, but you'll also use it with your stakeholders. And if you get it right, it's really specific about what it is that you want to achieve. So every good aim statement should possess all of these elements. So it needs to be specific. So you're making it really clear exactly what you want to achieve. Measurable, which we've already spoke about. So put in some metrics, some data. It's important to really think about how you're going to measure your project. Is it going to be in numbers, or is it percentages? Where you're starting from, where you want to go to. Is it achievable? So make sure that your project's realistic, and you convey that in your aim statement. It's relevant to your organisation, but also your department as well. And it's time bound. So make sure that it sets, the time frame is realistic. So it's specific. So this is what you're going to do. Have some data in there from to. Is it achievable? And only you will know whether it's achievable or not, because you know your capacity. Relevant, so it improves the organisation. It's going to improve our department, and be really specific on that date or time frame. So I've got a couple of examples for you, and these are other examples of dialysis examples from other K-QIP regions. So all units in Yorkshire and Humber. So the first one, I'm not going to read them out to you. The first one is specific because it's about CVC lines, and it's in Yorkshire and Humber, so we know which region it is. It's measurable, so we want to see a 10% reduction. It was achievable when we set it, and it's relevant. It's relevant because, you know, we want to reduce CVC dialysis, and it's time bound. So in a couple of months, we'll know whether we've achieved that. You know, if you look at the Southwest, so the second one, the Southwest want to improve their home therapies rate from 13.5% to 19.3%. So again, that's really specific, it's measurable, and they'll know by the end of this year whether they've achieved that or not. And this is one from Dorset, is to increase the number of patients on home HD from 13 to 17 by January 2021. Really, really specific. I think the key thing is having the measurement in there and it time bound, so that you know what you want to do when and when you're going to achieve it. And like I say, it's a really good communication tool. So you share that with your stakeholders, you know, they'll know exactly what it is that you want to achieve. And when you start telling people about your project, people will say, have you thought of what about this? And we call that scope creep. And it's really good to start what the scope of your project is right at the start, because those people could say it now, or they could say it 3 or 4 months down the line. And what we're saying, we're giving you the confidence here to say, actually, the scope of the project is this, and what's out represents not yet. So when those people approach you, you can say, actually, let's think about that maybe in 6 or 12 months' time. You're just saying it's just not yet. So that's that. So we're going to go off into breakout rooms. We do have 20 minutes. Rosie, Andy, are we happy to continue with 20 minutes, or do we need a little bit longer? Each breakout room is going to be facilitated. We've got these templates here that we will use to make notes. So yeah.
Well, we need to finish on time today, don't we? So we might need to shave off a little bit of time because we're running a bit behind. Should we try and get back to?
Should we do 15 minutes, do you think?
15.
Yeah. 3:45?
Okay.
Back at 3:45?
So,
yeah.
3:45. Okay. So Rosie is in the Preston team, Georgie the Wirral. I'll jump in the Manchester. Anu, I know, has got to jump off for another meeting, and Leanne in Liverpool. Okay, so we'll be back at 3:45 then. Yeah. Okay.
So have you put the links in the chat, Leanne, for us to
so
click on?
I've set it all up. It's all set up. So I'm just going to open it up, and then everyone should disappear.
Okay.
I'll press the button and see
By
what happens.
magic.
Yeah.
Fine.
See you in a bit.
I have to say, I love Teams and how it just
I know.
portals you from one place to another. It's very science fiction, isn't it?
We said that 15 minutes. It definitely wasn't long enough.
No.
Definitely not. But as I did say, we've got those dates, haven't we, Leanne, that we can add in at the end,
Yes.
and we can come back to. Right, just let me get the agenda up again. Let's just share that.
I think we're on track, actually, Andy.
Yeah, we're not too far off, are we?
Yeah.
So we've got a break, haven't we now?
Yeah.
So should we say 4 o'clock?
That give people 10 minutes.
Does that work, or do we want a little bit longer?
No.
10 minutes? Yeah.
10 minutes.
Start
Okay.
at 4. Yeah.
See you back at 4.
Yeah.
No problem.
Thank you all. Thank you.
Thank you.
Thank
See you back at 4.
Hi Fiona, it's Keith. Can I? Yeah. Can I have a quick word with Stephen? Just on a break from the Teams meeting. Ah, yeah. I was talking to Leanne Lockley, one of the organisers, and she said that really, if David and Andrea couldn't, as she put it, big up your peer support system, then nobody can, basically. I think if they just chatted through it and maybe put some numbers or some statistics or whatever, that would do for what they want, because it's going to be quite a crowded agenda, I think. And so I've sent you an email because I'm part way through a Teams meeting, but they just announced a break, so I thought I'd give you a ring. Oh, that's all right. Just yeah. All right. Yeah. Yeah, I just want somebody to illustrate how successful it's been, and it has. You know, there's no arguing with that. That'll be all right. Just send me his contact details. That'll be. Yeah. Well, I'm going to be on this Teams meeting till 5 o'clock at least, I would think. So it might get tomorrow now, but it's best I can do. All right. Yeah. 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 Okay. Yeah. All right. No problem. See you in a bit. Bye.
Everyone get time to have a cup of tea?
Yeah, stretch my legs.
Good.
So I've just got myself an Apple Watch, and every hour it tells you to stand.
Does it tell you? Yeah, it tells you when you sat there for too long.
Yeah, it tells you to stand, and I get very nervous.
It's always hard to know when everyone's back. It's like a little mystery.
Yeah. It's great teams, isn't it? Oh my word. Still can't get used to it.
Yeah. Catapulted into it in 2020.
Yeah.
How come we didn't know it existed before? Well, I certainly didn't know it existed.
All that travelling everywhere.
Shall we make a start?
Yeah, I think so.
Yes.
Yeah.
Okay. So I hope most of you are back. And I hope you got a cup of tea with you. So for the next 15 minutes or so, I'll do it a little bit quicker if I can. I'm just going to talk about driver diagrams. So I'll just share my screen. Right. Okay. Can you see that? Yeah. Okay.
Lovely.
So driver diagrams sounds a bit daunting. It's what us kind of slightly weirdo QI people like to talk about. But basically, the best thing I can say is it's basically your project on a page. Nothing more complicated than that. It's just a visual summary of your project, which can be very useful to be able to do that. So hopefully by the end of the next few minutes, you'll have a bit more idea of when to make it in your process, what it is, how it might help you to keep track of your project and communicate your project, what are primary and secondary drivers, and how to really use that driver diagram to help move your project forward. So we've all looked at this 10 steps in QI, focusing now on when to make a driver diagram. So most of you have considered points 1 to 5 so far in your projects. So we're now talking about how to develop change ideas, and really the driver diagram can help us to focus on that. We now got an idea what we're trying to accomplish. How will we know the changes and improvements? So we thought about measures. Now we're thinking about what changes can we make that might result in an improvement. So this is just an example of a driver diagram on home therapies, not wanting you to look at the detail particularly, but you can see that on the left, we've got the aim, which is a SMART aim, increasing the number of patients on PD from 85 to 100 by the end of December 2024. And these here is what we need to improve. So increasing the number of patients starting PD, increasing the time on PD, and being able to measure how things are going. So these are called primary drivers here. And this is more detail that feeds into those drivers, and I shan't go through that in detail. And to the right is change ideas. So primary drivers are these things here, these main themes that if we can make these better, and that may be more or less, if we can think those things better, then we will achieve our aim. And behind those primary drivers are what we call secondary drivers, things that if we do those things, it will make the primary drivers improve, and together those primary drivers will achieve our aim. And behind those secondary drivers is what can we do differently to make things go in the right direction. So how does it help you? First of all, when you get your team together to write your driver diagram, it brings you all together with a common purpose, helps you to share ideas, helps you to really start thinking in detail about what themes feed into your project and your aim. And it tends to help you realize that more than one way can achieve your aim. And that's when you're getting down into the detail of what you need to actually do. What are your drivers in your team and in your establishment, which may be different from somewhere else down the road. It helps to give your project a real focus. It helps you to break it down into smaller projects or sub-themes. So don't eat the elephant. Don't try and do too much in one go, because you probably won't succeed. It's helpful to break it down into different themes or drivers. And it helps you to understand the relationship between those different drivers, how you might measure each one, and what changes you can make in order to improve that driver. And it's a really brilliant way of communicating with your stakeholders. So you can make quite a simplified version of your driver diagram just to really show to your senior and other stakeholders what you're trying to achieve and what things feed into that. And it also helps you to get back on track. There will be times that you feel lost, like this little person here, completely lost in your project. You think, nothing seems to be working. I don't know where I'm going. So if you were out on a hike and you didn't know where you were going, you need a map to look at your map and try and look at your landmarks and work out where you're going and where you are at the moment. So your driver diagram is like your map of your project. You've got your aim here. You've worked out your primary drivers or themes that feed into that. And you've worked out the things behind that that help those primary drivers to improve. So it's a really good way of getting back on track if you're feeling lost. And this is something that I learned early on quite a few years ago when I was just starting out in QI and Leanne was teaching me. Go back to that driver diagram if you don't know what to do next. So we've already heard about our SMART aim, so I'm not going to dwell on that, but that's obviously a key part of your driver diagram, and we normally put that on the left. Our primary drivers, what do we need to improve in order to achieve the aim? And then to work out what our secondary drivers might be, how do we influence what we need to improve? And this can get quite complicated sometimes to work out what you should be putting there. And is it a primary or a secondary driver? And that's why you need to get your team together to actually work this out. And it will be a work in progress throughout your project. And then behind that, what are we going to do differently in order to move the secondary driver, which in turn moves the primary driver, which in turn achieves the aim? So we call those change ideas. And then with those change ideas, we pick them up and we do plan, do, study, act cycles to work out what small changes we can make and then build on that in order to start moving those secondary drivers. We'll be talking about PDSA cycles a little bit later today. So coming back to this home therapies diagram, driver diagram, you can start to see that these are the primary drivers here. These are the secondary drivers in the middle. And these quite detailed things on the right are some change ideas that this particular team felt would work for them. They may not work for you. So this is definitely not an example of what you should be doing. This is just an example to help you give an idea of what you might want to end up with further down the line. And it won't be finished today by any means. It will just be starting it today. So what we want to do in the breakout room is just to really start focusing on what are your primary drivers, what are your main themes that's going to help you to achieve your aim. You may get onto some secondary drivers as well. So what I'm going to ask you to do is just to brainstorm initially, what are the drivers for your project? Don't really worry whether they're primary or secondary. We're just going to write them down and think about including language like increase this thing or decrease that thing. And in order to have a driver in your project, you need to really be able to measure it, or else you won't really know whether you're moving that driver. So think about what drivers you can actually measure that are relevant to your project. In writing them down, you may notice that they tend to cluster in groups. So it might be, for example, things to do with PD tube insertion. It may be things to do with the patient choosing the right modality. It may be things to do with keeping that patient on that therapy, whether it's PD or home hemo or something else. And those will help you to sort of cluster them together and then think to yourself, well, what is it that leads to what? What order do those things happen? If it's the first thing, it may well be a secondary driver that leads to a primary driver that then leads to your aim. So have a think about the order, and you won't finish it today, but this is more of a starting point. When you've got those potential drivers, prioritize those that you think you can measure and also those that you can truly influence. There may be something that you think is relevant, but you've got no way of influencing it in the next 6 to 12 months. So that may be something to park, so outside the scope, like Leanne was saying, maybe something to think about for the future. But if you can't think of a way of influencing now, it may not be relevant to have that driver in your project at the moment, but something to think about later. And this, what you do today in your breakout room, will be just the start. It's important that you then take that back to base, because you'll have a lot more stakeholders in your project. So have it as a talking point and then do further work with it with your other stakeholders. And it really will always be a work in progress. Once you've been doing a project for a few months, it's good to go back and sort of consciously think, right, is this still the right driver diagram? Do we need to be putting in another driver? Have we actually solved one of these drivers? How much progress have we made? And it's always going to be something that you'll keep updating, and you'll come up with more change ideas, which will also need to be updated. So I think that's really all I need to share. Okay, so have we got a template, Leanne, for working in the breakout rooms on these drivers?
Yes, so I circulated a template for each of the facilitators about a driver diagram. So everybody's got this.
So are we going back into the same breakout rooms as we did before?
Yeah.
Yes, please.
Do we want to keep it at 20, or should we minimize it to 15 again, do you think? We're about 5 minutes behind at the moment, looking at the agenda. We've got 20. We had 20 minutes originally. Should we go for 15?
Do 20. I think we should do 20 for this, Andy.
Go for 20.
Yeah.
Okay.
Shave a bit off the next bit.
So 4:30. Yeah.
Okay.
Bear with me.
Andy's getting a dab hand at this.
I know.
See it on the other side. See it on the other side.
Yes, indeed. Mid-word.
We will.
Just got to save this before I lose it by accident. So Andy, I'll email you.
Yeah.
My homework. My work.
Right. Olivia, can you share that, because Olivia and Hannah have already started a driver diagram, so we cheated a little bit. We just amended what they had already had.
Some people have it easy, don't they?
It wasn't easy. It wasn't easy.
She had the easy group, Rosie. Just sharing where we're at with the agenda as well.
Glad you said that, Andy.
So, do we want? Is this the bit where we share what we've done so far, then, Rosie?
Yeah.
For 20 minutes or so.
We are a little bit behind time, but we have got a bit of time to do it. So, if people are happy to share what they've done, then we've just got a few minutes.
Okay.
And then I'll move on to just a very quick talk on PDSA cycles, which is what we want you guys to go away and do later.
So do you want me to start with the Manchester team then? I'll just share what we did. We didn't really have time to touch on John's projects, unfortunately. So we focused on the education side and the videos that the team have produced for the aim of the PD increase in numbers. For the aims statement, we felt that we definitely didn't have enough time. But we basically made a start, and specifically we felt that the main aim was for all patients in the AD-CKD clinic to have the option to access the education suite, and we set a time of by March 24. Keith rightly brought up that at the moment the budget or the finance is there, but it's still not set in stone as yet as to whether the media room has been sort of sanctioned, so it's still in the process really. Measurability, increase in the patient understanding of home therapies, the difference between APD and CAPD, all patients to have access to the media rooms and videos by March 24. And then we basically ran out of time really with that. And we, on the driver diagram, again, we focused on the videos. For all patients in AD-CKD clinics have the option to access the education suite. We're obviously going to need that suite for things to move on in a sense, increase patient understanding of the options, improve resources, the introduction of video materials. We weren't too sure whether we'd got these in the right way around, but we basically jotted as many things down as we could in the time factor that we had really. Budget, we think we've got the budget as surety, but as yet it's still to be confirmed. And yeah, that's probably about as far as we got. I'll stop sharing that one.
Do you want me to do Preston next, Andy?
Yeah, go on, Rosie, please.
Yep. Okay. Right, can you see that there?
Yep.
Yep. So the Preston presentation was sort of really 3 different projects. One was the Advanced CKD project. One was about dialysis access and one's about acute PD. We focused entirely on the Advanced CKD project, which is really about getting eligible patients into the right clinic, which is a multidisciplinary preparation for kidney replacement therapy clinic. So we wanted to be able to identify eligible patients. The GFR cutoff, we had some discussion that needs to be finalised, or would there be some different method of identifying which patients should be in, and they would be referred to the AKCS clinic. discussed about how we would measure that. Need an IT solution to be able to identify patients whose GFR is around about 15 and what clinic code they're in now as a baseline set of data, and then aim to have some kind of electronic report which could either be monthly or ideally live, so that you could identify which patients are not yet in the right clinic service and pull those through. We talked about whether the aim would be a percentage of eligible patients or an actual number. We thought probably percentage of eligible patients would be the right way to go. Whether it's achievable or not, that depends on clinic capacity. And the aim would be perhaps a percentage improvement on what we have in the baseline. It's relevant because it's improving access to advanced kidney care, which is a GIRF target. It can definitely be time bound. We need to work out what a realistic deadline would be. So our sort of draft aim statement will be to reduce the percentage of eligible patients whose GFR is less than 15 who are not in the right clinic yet, basically, from something to something to yet be decided. And the date I've put here was arbitrary, but really just something for the team to work on. And then looking at the driver diagram, so we've just put that aim in on the left. So in order to do that, we felt we needed AKCS clinics in all sites. We needed data to identify eligible patients. We need increasing staffing for the clinics. The medical seems to be sorted, but it's the nurses and the rest of the multidisciplinary team that needs to increase. We need engagement in terms of staff education and patient communication, and a referral process. Not quite sure whether that would be a primary driver or whether it would sit behind this top driver here. And then secondary drivers we've kind of put here about having admin and manager support to get the patients moved across. We've got a start date, which is November. Some work to be done on the data. So Preston team have got two great IT people, Hannah and Scott, who are well engaged but need to understand about this part of the project. Need to work out a process to review that data each month and ideally use the new vital data system to create a live report. So that's a new thing to be done. We need to increase the staffing of the MDT parts of the team. So that'll need to be a business case. And I think that's everything.
Thanks, Rosie. Leanne?
So Olivia, are you able to share your screen? Because you worked on that driver diagram, or we worked on it together, but you made the changes. Well done. I think you're on mute, Olivia.
Sorry, I'm not good at multitasking. Is it there? Can you see it?
Yeah, I can see it. Fantastic.
Okay, so for our aim, we said we would our aim would be to measure and review the renal IPAS score with a supportive MDT in 30% of appropriate patients in centre HD units by next November. So our primary drivers will be to formulate an MDT plan, staff education, patient education and engagement. We need to identify and record our measurable outcomes, and we need to engage the rest of our department. Hannah or Leanne, do you want to add anything there? Or?
And I think because Hannah and Olivia had already developed this before today, it was really difficult to sort of say what was a primary driver and what was a secondary driver, and we were sort of getting ourselves in knots a little bit. But I think we got our primary drivers. Basically, we want to improve all those primary drivers. We want to improve our MDT, we want to improve our staff education, and want to improve the patient education and their engagement. So I think we got the primary drivers right. The secondary drivers, they were a bit more tricky, actually, I think, to define what they were. But I think it was a really good start.
I think we found it's difficult in the time frame, isn't it, to kind of truly focus, and then the time just disappears, doesn't it? But great work. Georgie?
So I'll stop, sorry.
Let me share my screen. I don't know if one of the team at Will wanted to talk it through. Can you see that?
Yeah.
Yep.
I'll talk it through. I'll talk through if that's okay with Lamise and everybody. So after the 3 projects that we've got, the one that we looked at was with the broad title of trying to improve our attrition rates. So our aim is to reduce the drop off of patients from PD to in-centre hemodialysis, because obviously we lose patients from PD, sorry, for reasons such as transplant and moving out of area, etc. So the main reasons why we're losing the patients are infectious complications, exit site rates and peritonitis, and PD patency as well. And also we just felt we needed to be able to demonstrate the data as well. They were our 3 kind of primary drivers. So within the infectious complications section, we wanted to look at things like the pathways for patient education, making sure patients are assessed regularly, new patients in particular, but also focus on the PD cohort that we already have as well, make sure that their hand washing, their machine setup technique is as trained. We wanted to look at staff education as well and all the different protocols that we have, because we train in-centre we train in-house rather with our own team, but we also use the Baxter Educational Facility just to make sure that the pathways are equitable across all different resources. Improving access outcomes as well. We also obviously wanted to do root cause analysis with every patient that we lose from PD to in-centre hemodialysis, whether that be whatever reason it is, but certainly focus on an RCA for PD peritonitis. So we'd be a bit more in line with ISPD recommendations at that point. But also look at reasons why we've lost them if it's a non-patency issue. Was there something that we could have done? Were the catheters going in early enough? Were we flushing them appropriately? Did they start at the right time for them, etc.? Looking at surgical slots and make sure that we have access for patients when they need to start dialysis, but also access if we have any issues, that we're not holding a patient off PD and then they have a neckline in and start on in-centre hemodialysis and never come back to us, which is something that we're all familiar with as well. And then we were just kind of looking at lots of other different change ideas, and we've just got them in different sections here. But again, we ran out of time. We felt that this would probably need the team to kind of come up with more kind of change ideas as well, rather than just the ones that are on screen now. We needed at least 4 times more time.
Thanks, Angela.
Thank you.
Some great work. So I think we're back on track. I think we've got 10 minutes, Rosie, just to prioritise and test change ideas.
Yep. So this will be quick. So this is just to get you started with thinking about what to do next with your project, really, which is to start looking at those change ideas and testing them on a small scale. Hopefully you can see that on the screen now. Yep. So basically, plan, do, study, act cycles. You'll have heard people talking about PDSAs. It's a way of testing and improving things on a small scale with small steps. So you're not doing anything drastic. So we're just going to cover a little bit how to do this. Why do we do PDS cycles? How do you develop one? What are the components to doing one? And how can you collect and share the learning? So we're now on to step 7 of this 10-step process. So why do them? So a lot of the time you start your project and you think, I know exactly what I need to do. If I just change this thing, everything will get better. But unfortunately, we've all been victims of having that done to us and seeing the consequences and realizing that in complex health systems, which we're all in, it doesn't usually work out quite as well as that. So I'd have the analogy of, would you jump straight into a hot bath without testing the water first? Well, none of us would. And we certainly wouldn't put our small child into a bath without testing the water. So actually, when you're running a bath, it is like doing a PDSA cycle. You put the water in, you test it, you change the tap, you put a bit more hot, a bit more cold. So doing a PDSA cycle is like dipping your toe in the water, working out, is it right yet? And then tweaking the bath water until you get it right, in very simplistic terms. So if you're the person that is kind of using the service and someone makes a change that doesn't make things better, it might actually make things worse. You'll often be thinking, why didn't they speak to me before they changed everything? I could have told them what they needed to do, or I could have given them some ideas, or can't we just try it out on a small scale before we change everything? And that is really where PDSA cycles come in, which is turning all of these ideas that you might have come up with in your process mapping or your fishbones. You'll have come up with some change ideas, turning all these little things that you might have on post-it notes or virtual post-it notes, turning them into action. So you'll have a lot of those ideas, and the question is, what do you do first? What's it worth putting your time and energy into? So we often use this really simple matrix, which is something that Leanne taught me many years ago. So try and categorize your change ideas into, are they going to have a high impact on your project or a low impact? And are they easy to do or are they less easy? So often the ones that are easy and high impact are what we call quick wins, or you might hear someone calling it low hanging fruit. These can get a little bit of a cliche over time, but there are in every project some things which are probably easy and high impact that you can start doing now. And those are the best things to start off with your PDSA cycles. There may be some other things which are really easy, but the impact may not be so great, but you might just be able to delegate those. So when you identify those types of things, think about who you can delegate it to. It may be something that's really an admin task that if you just get that sorted out, it'll just help things run better for the future. There may also be some things that are actually potentially very high impact in your project, but they're quite difficult to get started. So we talked in the Preston project about getting the vital data system to start producing a live report of the people who aren't in the right clinic yet. That's something that would have a high impact, but it just can't be done immediately, but worth working towards. Then there are some other things, some ideas that might have cropped up, which are less easy and they're low impact. So just don't do those. They're outside of scope for the moment. They may or may not become relevant later on. So there's a certain cycle in this PDSA process. So first of all, you're going to plan it and you're going to start to predict what you think might happen if you start to test this change on a small scale. And we're going to give you some template to work on. So you're going to think about what's the question you want answered by this little test. Write down what you're actually going to do, who's going to do it, when you're going to do it, and where or how you're going to do it. So fill in this kind of table here. Plan how you're going to get it done, the tasks needed in order to make that change, who's going to do those tasks, when they're going to be done, and try and write down a prediction of what you think is going to happen. And it's always useful to compare the prediction with what actually happens next. So the next stage is to actually do. So you're going to run that change and you're going to observe. It's really important that you do this observation and measure what's going to happen next. So you then come back together as a team and describe what actually happened. You may have found it made things a lot better, or it may actually have had the opposite effect, or it may not have really done much at all. So describe what actually happened, what measurements you took, what it showed, and try not to be biased, because we all want to show that what we've done has made things better, but it doesn't always. And it's really important that you're honest with yourselves and your team about what actually happened, and write that down and think what you learnt, comparing the prediction with what actually happened. And then you're going to study what happened. So compare the prediction with the outcome. And then think about, okay, so it did this. What are we going to do next to try and make it work better? Or actually, is it something that was a terrible idea? Scrap it, think of something entirely different. Or is it that it could have worked, but we didn't have the right people on the team, we hadn't engaged properly, so it didn't really work properly? So think what you need to do in order to make it work better than it did the first time round, because most things don't just go perfectly the first time you do them. You might achieve something, but think, oh, it could be better if we did this or that. And then you plan your next cycle. So write down how are you going to modify it the next time round, and you go through the same thing again. Predict, observe, measure. And then you might find that you go from hunches or theories or ideas at the beginning to different runs of PDSA cycles. So you test it on a very small scale, make a change, do it again, and then you might want to do it on a wider scale. So for example, Hannah and Olivia's using the IPOS score. They might want to use it on one patient initially. What happened? How was it for the patient? Learn from that, do it on a handful more patients. Do it in one unit, and then you might think, okay, we've learned how to do it in one unit. Are we going to do it in another unit? And to make it work in a second unit, you may need to have a completely different plan from making it work in the first. And hopefully by doing these iterations, you will eventually result in changes that can achieve lasting improvement. And then finally, some top tips. So plan multiple cycles, expect that it's not just a one hit. Test it on a really small scale first. Do test it with those who are already believing in the process. Don't test it with the people who are yet to be convinced. You want to have your followers with you. Make it easy for yourselves. And then eventually you might need to work out how to engage the less convinced people. Keep doing changes and only implement the idea fully when you've exhausted the improvements that you think you can make. So by implement it fully, I mean implement it on a wide scale. You need to learn first about how to make it as good as it can be and as easy as it can be. And that is everything. So your homework will be to look at your change ideas and prioritize them and think which ones to start with. Pick something easy first.
Thanks, Rosie. It feels like we've crammed a lot in today.
Yeah, and
it
we're
feels
not
like
finished.
Yeah, I know. Sorry, Leanne.
That's okay. So just going back to that Mentimeter, let me share the screen so everybody get their phones out. I just like to understand, and I'm just going to repeat those questions that we used before. Okay, I think we're okay to move on, yeah. So now how confident are you at developing a SMART aim, knowing what SMART means? That's good. We want to just increase your confidence, either a big much or a little much. So that's fantastic to see. And I'm going to repeat the next question if I'm okay to move on. About driver diagram. And remember before, I apologise for using that QI language. So now when you're in the QI world, as you are now, when you hear a driver diagram, you'll know exactly what people mean. It's that project on a page. And it's okay to not feel confident because a driver diagram is kind of tricky. And it's a team sport, okay? So you don't do it on your own. And Andy and I'm just going to share some dates with you in a little bit. Right, okay to move on. Fantastic. So I'm just going to stop sharing my screen. And now it's time to get your diaries out. And it could be actually that we just send these dates around via email. But Andy and I really want to support you on, you know, firming up your aim. And just put that bigger. We really want to help you firm up your aim, develop that driver diagram, and you start thinking about that priority matrix, about prioritising change ideas. I think that's sort of the homework that we want to support you with. So these are the dates. You know, you can take a screenshot of them, have a think, and you can let us know. I think just because time. Just because of time. We'll send these around in the email as well, and you can let us know what's best for you. And just to let you know that we are doing a patient-focused dialysis education day on the 15th of November. This is the registration form, that QR code, and it is going to be on dialysis. So our home therapy projects that we've heard about, the project from Liverpool, all our projects, we want everyone to share what it is that you've been doing. So welcoming introductions, lived experience of dialysis. I just want to go over the World Cafe session a little bit more. So one of the feedback that we got at a previous face-to-face event was it was lots of presentations. So we've devoted 90 minutes in this World Cafe session where each project, so you know, we know that Wirral's got 3 projects, Preston have got a couple of projects, so all the projects will have an area in a room. We're going to have more than one room at this event. So each project will have a small area, a small corner, a table where you will give a 5-minute presentation, and we'll get people to move around each of these stations. So it's a World Cafe session. We'll ring the bell, so you'll have 15 minutes per table. 15 minutes, we'll ring a bell, and then you move on to the next presentation, the next table that you want to go to. So this is self-directed. This is what you want to hear. So the case is really between now and then, you know, we're going to help you put these presentations together for you to share with the wider community. So that's sort of really the call at November. You know, we're expecting all the projects to have a table, to have an area in a room to share your projects. And we've got Georgie coming to share the day life. We've got Tanya Barnes coming to tell us about shared care. We've got David Coyle from NKF and Keith coming to share the peer support programme. We're going to have some lunch, and then we're going to give you some, you know, a good 60 minutes to work on your QI projects, to think about shared care. How do we involve peer support, or just to work on your QI project a little bit more? And then we'll have sort of a wrap up session. So not necessarily finishing at 4 o'clock. We could have some other activities in there, but I just wanted to bring that to attention. And I'm conscious that it's 5 o'clock. So just before you leave, please give us a feedback. Let us know how this workshop has been for you. It just helps us to improve the next one. We do take your feedback. We do read your comments. It's really, really important that we make these workshops the best they can be for you. So I'll stop sharing my screen.
Thanks, Leanne.
So please try and book study leave for the 15th of November, because it's 2 months, 8 weeks or so. Still got time to book study leave and cancel clinics. Or not.
Yeah, it'd be good to see everyone.
Keith's thinking, no, don't cancel the clinics. The poor patients need to come to clinic.
Any questions on today? Anything to add? I think we've crammed in quite a lot. I think the breakout rooms certainly help, and we just probably don't have enough time in there, do we, to complete. But we've made a start on some great projects going on, and it's brilliant to see so many people working on the projects at the minute. I don't think I've got anything to add. I think Anu had shot off to go to another meeting, so we'll catch you again. If you have any, we'll email and circulate those dates out again, those support working dates on Teams, and we look forward to hearing from you again soon. Sorry, Louise, do you have any? Oh yeah, okay, no problem. See you later. Thank you.
I need to pick
Thanks,
up my
everyone.
son from school.
Thanks, everybody.
Bye, everyone.
Thank you.
Bye.
Thanks.
Thanks, everyone.
Just wondering, Andy, if you can stop.
Yeah, just stopping recording.
Thanks.